Today is going to look at case studies from the VTE Exemplar buddy system. Chairing this meeting is Emma G. Emma is a nurse consultant in thrombosis and coagulation at King's College. Having worked in the UK and Australia, Emma joined King's thrombosis team in 2014 as a coagulation clinical nurse specialist, and she rotated through DVT, anticoagulation, and VTE prevention roles. In 2018, Emma completed an MSc in Advanced Practice and Leadership at King's College, London, and now leads the VTE National Nursing and Midwifery Network.
Thank you very much, Jo, and thank you as always for the amazing conference that National Thrombosis Week have put on, and for inviting us to talk today about the VTE Exemplar Centre buddy system. So you may well be very aware of the GERF, the Getting It Right First Time VTE report that was published in September last year, and it provided a snapshot of the VTE processes and achievements across England. And out of the recommendations, number 7 was that development of a buddy system for trust not meeting the 95% risk assessment rate, with a VTE Exemplar Centre to share best practice, provide mentorship and encouragement, was number 7 in the recommendations out of 14 recommendations. So currently we have got 8 live partnerships throughout England that have commenced working together since October last year. And the plan is to follow these partnerships and assess their effectiveness, and with the possibility of providing a framework and some guidance in future for these working relationships. And today I'd like to welcome some colleagues from some of the buddy partnerships who are currently ongoing, who are going to talk about their experiences so far. Now, this session today is all about you hearing what you need to hear. So please contribute by writing your questions in the question box that you can see there, and we will endeavour to answer any questions that we've got. I'd like to really warmly welcome my colleagues today and thank them very much for giving up their time to join us at this session. Just introducing my colleagues, first we have Becky Walsh, who is the lead pharmacist for anticoagulation and thrombosis prevention at Sheffield Teaching Hospital. And Becky graduated from Bradford University with a master's degree in pharmacy and completed a postgraduate diploma in clinical pharmacy in 2005, completing rotations through various medical and surgical specialties. Bex is now employed as the thrombosis prevention and coagulation pharmacist at Sheffield, and is an active member of the Yorkshire and Humber Anticoagulation Pharmacist Group and professional secretary of the local thrombosis committee. So Sheffield is an exemplar centre and has been working with Hull University Teaching Hospital since the end of last year. I'm going to introduce my other colleagues and then we're going to come back to Bex. We have Becky or Rebecca Simpson, and Becky is lead nurse for VTE prevention at Ashford and St Peters and a member of the VTE National Network for Midwives and Nurses. And Becky joined Ashford and St Peters Hospital in 2013 and established the VTE Prevention Service, which achieved VTE Exemplar Centre just 3 years later. She continues to oversee VTE prevention and has been nationally commended for this. She's currently working for a newly established multidisciplinary harm-free care team. Ashford and St Peters is an exemplar centre and has been working with Dartford and Gbson NHS Trust since October last year. So we'll be hearing from both Becky and colleagues at Dartford and Gbson later on. We have Claire Gibson joining us today, and Claire is a chartered scientist and fellow of the Institute of Biomedical Science with nearly 40 years service in the NHS. I can't believe you're old enough for that, Claire, most of which has been spent in the laboratory. Maybe that has kept you young, being in a lab all that time. Claire practiced haematology and blood transfusion and further specialised in haemostasis and anticoagulation, which included gaining an extended practice qualification in anticoag therapy management. In 2019, Claire was appointed to deliver and manage a new community point of care INR service for local patients. And in order to improve patient safety, she re-established a thrombosis group at the Trust, and now they're working towards exemplar centre status and have been working alongside Guy's and St Thomas's Hospital in London, which has been an exemplar centre for many years as their buddy site. I should say Claire works at Princess Alexandra Hospital in Harlow. Next, I would like to welcome Dr. Natalie Heeney, who is a thrombosis lead at Dartford and Gravesham NHS Trust. Having studied haematology at Guy's and St Thomas's, she qualified as a consultant in 2018 and became thrombosis lead at Maidstone and Tunbridge Wells NHS Trust before moving to Dartford and Gravesham in 2021 and taking over thrombosis lead there. Natalie has a special interest in cancer-associated thrombosis. And finally, I'd like to welcome Susan Rust, who is a VTE nurse at Dartford and Gravesham NHS Trust. After working as a healthcare assistant for many years, she trained at Greenwich University and has worked at Darren Valley. After years in respiratory and clinical decision units, Susan worked in palliative care until the start of COVID, at which time an opportunity became available for a VTE role. And Susan says, while she lacks experience in the field, she's prepared for a challenge and is being very well supported by colleagues. And both Natalie and Susan, as I said, are being supported by Becky and her team at Ashford and St Peters. Now, first of all, I would like to welcome the first buddy case study, and Bex Walsh from Sheffield is going to talk to us about your experience of the buddy system in your role as a mentor to colleagues at Hull Hospital.
Thanks, Emma. Hi, everyone. There's a question in the Q&A already. Brilliant. This is what we love, so please keep them coming. So I was approached by Emma via the NNMN network to make contact with a specialist registrar in Hull University Hospitals. They were struggling to meet 95% risk assessment target and were just keen on picking the brains of somebody locally to see how we'd achieved it. And I mean, my understanding of what happens behind the scenes in an organisation was massively challenged when we started doing the risk assessment process and trying to achieve 95%, because department side I never knew about. There were just ways of working that I'd never appreciated. So I was able to, we had a couple of Zoom chats, and then we included the chair of the thrombosis committee in Hull in some of our discussions. So we were able to talk through really all the elements from sort of start to finish, left to right, top to bottom, of the things to consider. So, for example, we spent quite a lot of time talking about the cohort exclusion groups, and how she'd never heard of that. So, and how they might be identified sort of centrally, and what procedures or admission types would be suitable for a cohort exclusion. And those lists can be revisited as time goes along. I think, when we started this process, gosh, probably 10 years ago, the nature of admissions were very different. So there are now lots more day case procedures and procedures done under local anaesthesia. So those are the sorts of things that you can go back and look at and tweak a little bit. So for her, there was a sort of a much bigger picture in how this worked within the organisation that she didn't have an understanding of. She was an anaesthetic registrar doing a quality improvement audit. So her understanding was really localised and specialised to anaesthetics. So we sort of zoomed out a little bit and talked about some of the sort of central approaches, and I mean, the other major factor, it was senior buy-in. I think it was the lead clinicians and senior colleagues getting on board and taking it seriously and motivating the right people to make it happen.
Can I ask Bex at this point, was her main focus and remit around VTE risk assessment?
Yes, it was. I feel as if the next step to that is always prescription of appropriate prophylaxis, which you can have one without the other, but the point of this is to improve patient safety, isn't it? Reduce the risk of hospital-associated thrombosis. So she, I think, was coming at it from a risk assessment and with the 95% target very much at the front of her mind, but as a clinician, especially as an anaesthetist, she had an appreciation of sort of all elements of VTE prevention and the methods you might employ, and when it might be inappropriate to use pharmacological methods. You know, her knowledge of the detail was in that sort of the clinical field. So it was the processes and the different pathways. How do patients enter the trust? What are we doing digitally? What are we doing on paper? Who's leading this? Who's reporting? Who's even responsible for who's actually interested in the numbers? Is anybody looking at the numbers? Is anybody doing anything differently? Is it influenced by the numbers? So it was that sort of zooming out that I think that was helpful.
So logistically, did you have meetings on Zoom or Teams?
We did Teams meetings. Yeah. I mean, Hull's not all that far away, but at the time we were doing a face-to-face meeting, and we just did the initial sort of chats were fine to be done by Zoom.
Yeah. And so in your sort of input, do you think it was around looking at processes and helping them to kind of get some clarity around how they can make VTE prevention work for them? Do you think that's what your main actions were?
Yes, I mean, she had a service improvement goal. So she had a short or a fixed term with a clear endpoint, and as I said, her sort of clinical understanding, and I think even sort of
seem to have lost. Are you back, Bex?
Am I back?
You're back.
Great. Oh, sorry, I don't know what that was about.
Don't worry, you're back.
They had very limited input from their haematologists, actually. So there was something for me to learn there about. All right, so my default would be to go to we've got a haematology lead for thrombosis prevention. How do you do this without a haematologist on board? Who do you need to engage with? The thrombosis committee, and it was chaired by a surgeon, very very keen to improve care, but it wasn't led by haematology, and that was a bit of a surprise to me. But it just goes to show that not every model is the same, and you learn from each other and you take out bits that are relevant, and apply them where you can.
Yeah, I think the important thing is that somebody is leading it and somebody with an interest in it who's going to take responsibility. Talking to a colleague yesterday who was finding that very difficult, getting somebody who is engaged. I think it doesn't matter too much if it isn't a haematologist, as long as they are motivated and like I say, they have that level of accountability, I think. So where do you think that you were most able to add value as a buddy site for Hull?
I feel as if we can add more value. I'm not suggesting that we've done as much as we can do, but certainly I feel as if being involved sort of at the beginning almost, although not in terms of timescales, but just starting at the beginning of the process. So the suggestion of reviewing the cohort exclusion, she wasn't aware of that. And actually that can be quite a significant group of patients. I think, again, sort of right at the start in terms of senior engagement and making this somebody's priority, because it was a sense that nobody really owned it. And our experience is that somebody has to be bothered about this. Somebody in the medical director's office has to be agitated enough to take action. In terms of sort of the nitty gritty, I don't think we added a huge amount of, whether to do it electronic or paper based and whether to have VTE champions and all that sort of thing. We weren't really involved in that discussion. I think they had the bare bones there, but it just, there was this big disconnect between what was happening and what should have been happening, and anybody who was really charged with making it better prior to her coming in. So I don't doubt we can and could have done more. I haven't heard from her recently as to how it's going, but that's certainly where we seemed to come in, was right at the start, all the sort of the behind the scenes sort of stuff. And yeah, would be happy to do more. There's always more to be learned, I think, from other organizations. And just because you're an exemplar centre doesn't mean that everybody in your organization is as interested in VTE prevention as they should be, or you are, or there's always tweaks you can make to improve.
Absolutely. And I'm glad that you picked up that you learned from them as well, because I see it very much as a symbiotic relationship where we learn from each other. Like you say, no two centres do things in exactly the same way, and it is always interesting, isn't it, to get other perspectives and see how people do it elsewhere. And so in terms of the plan, did you make a plan at the outset, or did you kind of let it go quite organically as to how they needed you in terms of your level of input?
It was organic. So she and I made contact, I think had a little chat, and then we brought in the consultant, the thrombosis committee chair from Hull, and one of our nurse specialists, and I think our lead consultant, so that there was just more of a multidisciplinary approach and just a bit of a broader way of thinking. So we met, I think, on Zoom a couple of times all together, and then we said, look, just do these things, see how it goes, come back to us if you need us. So we weren't particularly intense in terms of our level of support, but we didn't want to be too sort of in your face.
Yeah, no, I think that's the right way to do it, isn't it? That to leave the ball in their court, and they knew that they could contact you. There is a question. I wonder if you want to have a go answering. One of my hospitals does not meet 95% as reported. They say they do really, but the reporting system is at fault, something that we do hear a lot. Could a buddy system help them? And from your experience, Bex, I know it's quite difficult, just your experience of one buddy relationship, but do you think that is the type of thing that a buddy centre could help with?
I do, yeah. I think there's all sorts of different ways of approaching this target, and just getting ideas from somebody doesn't have to be a particularly sort of intense relationship, but just a sort of chat. How are you doing it? Any ideas? Have we thought of everything? It always fascinates me how trusts have evolved. No organization is designed the same way, and even sort of thrombosis, some places it's ED, some places acute medicine, some it's hematology led. That even just on a sort of taking that tiny example, multiply that up by systems and reporting and coding and all sorts of information communication, then you're best placed, I think, to know what is relevant to your organization, and who is likely to be the mover and the shaker, or whose ear you need to bend to affect change. But certainly, we want to learn from each other, and there'll be things that you thought of that I haven't, and vice versa. And so yeah, definitely.
Yeah. And I should just say, actually, for any listeners wanting to know more about the buddy system or wanting to apply for a buddy system, on the vteengland.org.uk website, you can click on a link there that will take you to a very short application form that will come to me, and then we will find a VTE Exemplar Centre buddy for you. And I should say as well that in the GIRF report, it talked very much about wanting to achieve 95% risk assessment, but I'm sure all of my colleagues with me today will agree that that's not the sole focus of VTE prevention, certainly, and and certainly the buddy system. It's not just about VT risk assessment, it's about all of the processes across providing quality VT prevention care. Thanks so much for that, Bex. We may well bring you back into discussion later, but thanks for that insight. Next, I'd like to welcome colleagues who have paired up together, Dartford and Gravesham NHS Trust, Dr. Natalie Heeney and Susan Rust, being supported by Becky Simpson from Ashford and St Peter's to share their experience. Are you going to talk first, Becky?
I can do, if you'd like. I won't say much. I'm going to leave most of it to Natalie and Sue.
Thank you.
So much the same as Bex, Emma approached me to ask if we would buddy up with Natalie and Sue. Straight away I said yes. I thought it was an amazing opportunity, and that was followed immediately by a bit of trepidation. I thought, oh my goodness. This is quite a big thing, and as Bex kind of alluded to earlier, I'm quite an in-your-face type of person, and you don't want to be too kind of overwhelming. And thankfully, Natalie and Sue are complete powerhouses. They've got complete focus of what they want to achieve, and they're very much, this is what we want to know about. This is what we want to look at. And as Bex was saying, it was very, very organic for us as well. We've been very informal. We had kind of our initial meeting, I think it was on Teams. And we just kind of said, these are the sorts of things we want to look at, and said, I'm here, you can call me, contact me, email me whenever you like, and we kind of took it from there. And actually, for me, being kind of the exemplar buddy site, it's been so valuable, because as has been alluded to before, and I just want to echo, it's a collaborative relationship. And actually, when we've been discussing things and looking at things, it's made me think, oh, I think we need to relook at that and think about perhaps, that's good, but it can be better. And what could we do differently at our site as we've been talking through it? So for us, we've definitely kind of learned from it and driven practice. And it's all about driving that quality, isn't it? And driving the improvements and responding to what's going on, because the organisations are different, and what works for us at Ashford and St Peter's may not work for Natalie and Sue, but it just gives an idea, and things that Natalie and Sue are doing, I think, oh, actually, yeah, that, I could take a bit of that onto our site. So I mean, for me, it's been really an enriching experience, and it's really nice to have like-minded people to talk to who have similar interests, because I'm sure most of my colleagues will agree. Sometimes when you're talking to colleagues within your own organisation, you are probably the only enthused person, or there might just be a couple of you, and it's just nice to be able to talk to other people. And interestingly, when we started at Ashford and St Peter's, it was just myself and my colleague Dr. Tanya Bernard, just the two of us, which kind of very much mirrors what Natalie and Sue have got going on now, and they're kind of facing the same challenges that we had. So it's quite nice to be able to share what we did to overcome that.
Yeah, you've been there and done it, and it definitely resonates what you're saying about needing to review your own processes, and it does sort of turn that mirror on what you're doing. I think some of us have had these processes and systems in place for many years now, and actually talking to somebody else about it makes you think, hang on a minute, maybe we do need a refresh. I think a lot has happened, a lot's changed since then. Thank you.
Don't you?
Yeah, absolutely, of course.
Working well.
Yeah, absolutely. Yeah, so it'd be lovely to hear from Natalie and Sue, to hear their perspective of how the buddy system worked.
Yeah, absolutely. So just to give a bit of background, when I started the trust in September, I was asked to become thrombosis lead, and there hadn't really been a thrombosis lead for some time, and that was a culmination of retirement, nobody, stepping into that position that was interested or enthused about it. And unfortunately, the clinical lead for haematology passed away unexpectedly as well. So they had quite a lot of, things to deal with. So having joined in September, it became quite clear that there'd not been a thrombosis committee meeting for about 9 months, nobody really chairing it, and there were a lot of processes that really weren't kind of set up, so I almost had a completely clean slate to deal with, which was quite overwhelming, to be honest. And the way that the hospital investigated, hospital-acquired thromboses was very different from where I'd worked previously, and it was very much a kind of clinical governance-driven exercise. with not many clinicians involved, and not much getting fed back to the clinicians either. So it was actually this meeting, I think last year, when I heard about the buddy system and contacted you, Emma, and you put me in touch with Becky. And it's just been invaluable, because she's been very helpful with sharing the processes and pathways that she's got set up. And it's just getting to grips with how we can make it work in our hospital. And we've certainly taken on some of her processes and pathways, but have kind of adapted them to make it work more locally. And it's nice just to be in touch with somebody that's also enthusiastic, because when I chaired the first thrombosis committee meeting, I think we had like 2 people turn up, and it was utterly, distressing and very despondent. But the last thrombosis committee meeting, so the third one that I've chaired now, we had input from so many people that it was amazing how much it had changed and progressed in just the, 8-9 months or so since I've started. And that was just really, really nice. We've got loads of work we need to do, but we certainly have got a more robust process now that's been set up to investigate hospital-associated thromboses, and more importantly, how we feed back to the clinicians and the nursing staff and other allied health professionals about things that perhaps could be improved or where it went wrong. So I think that's certainly moving forward. We're definitely not hitting our 95% VTE risk assessment, and I spoke to Becky about that only yesterday, but she's given us some really good ideas about how to kind of go away and look into that in a bit more detail, and I suspect we probably are. And it's a reporting issue, because you trawl through all the drug charts and they've all had a risk assessment. I'm not saying that they've all been correctly filled out or they've received the appropriate thromboprophylaxis, but we very rarely don't come across somebody that's had a risk assessment. So I'm sure that that's just a data entry issue. So I would really highly recommend the buddy system for anyone that's thinking about it, because it really has been invaluable.
That's fantastic. It sounds like a real success story, and it sounds like you've made an awful lot of progress in a short space of time, actually. So congratulations to you and to Sue. It must have been a lot of hard work.
Yeah.
Sue, have you got anything to add from your perspective?
I was completely a novice to this. I was a palliative care nurse, as I said, and I got one Friday in December, I got asked, would I like to be the Trust VTE nurse? And I didn't even know what it meant. I had to go and Google it. But it's been really interesting. And one thing I would say is, and perhaps it's because I'm older than Natalie, just don't get despondent. You may only get a little win every now and then, but you never go back to how bad it was. It's a bit like, I don't know if I can think of it, like bereavement. You get bad days, but you never go back to how it was when it first happened. So yeah, the second meeting, Natalie, wasn't very good either, was it? There was only about 3 of us. But then, as you said last time, it is taking off a bit. So yeah, just don't be despondent, I think, was what I would say to hospitals starting this process. You do a little bite every now and then, and
have you found, being new to the role, have you found the support from Becky and her team useful?
Yeah, totally invaluable. As I said, I didn't know where to even start, but she there was an email that I went back to Natalie and said, I don't understand a word of this. And Natalie said, just stay calm, we'll go through it together. And we did, and we picked out the bits that I could do and that were pertinent at that point. And now if I look back at that email, I've done that and we've done that. But it's just, I've forgotten what, there's an expression, touchy, smally, feely or something. And it definitely is the way to follow. Don't try and run before you can walk. Yeah,
it can feel a bit overwhelming, I think, if you're starting from scratch and you feel like you've got a mountain to climb. And I think it is looking at, I always think it's about looking for the easy wins and because that improves morale, doesn't it? It makes you feel like you're making progress, but also looking at the priorities, you know, what is really going to make a difference to patients? What can we do that's really going to make that difference? And I think, like you said, Natalie, feeding back the learning from the root cause analyses is so important, isn't it, in informing practice and making sure that we don't make those same mistakes again. Fantastic to hear from you both. It does sound like it's been a very positive experience for you. And so I'm assuming that you would recommend the buddy system to other centres.
Yeah, absolutely.
Do you think that it would benefit from being more structured, or did you actually like the fact that you could go to Becky with your own list of things that you wanted to achieve and kind of do it your way?
Yeah, I think being able to do it your own way works for us. You know, we really were starting afresh, whereas you know, I'm sure lots of other trusts have got, you know, certain aspects set up, but maybe just need help with other aspects. So I think having a more informal arrangement, you know, it worked really well for us.
Yeah, fantastic. That's great. Thank you so much. We're now going to come to Claire. Claire Gibson works at the Princess Alexandra Hospital in Harlow and has buddied up with colleagues at Guy's and St Thomas's Hospital to look at their VTE prevention pathways, which I think, Claire, you were already doing an awful lot of work on, weren't you, before you buddied up? But could you tell us about your experience, please?
Sure. Thank you, Emma. Thank you for your kind introduction earlier as well. I think Zoom's very forgiving on the wrinkles. Anyway, yes, so a bit of background, and actually very interesting to hear what Emma's saying. There's so many common themes here with what I'm going to say. But our trust had a bit of a gap. We didn't have an active thrombosis group, and myself and the new patient safety lead were very conscious of that gap. And again, it's who's going to do that, and that person was me, because nobody else was doing it. It doesn't have to be a nurse. It needs somebody who's got a will and a desire to improve patient safety. And so it was a bit, you know, I have a lot of gaps in my knowledge from VTE point of view, and how was I going to tackle this? So my first thing was obviously looking online, VTE England, and when I looked into the Exemplar site set up, that's the perfect framework to introduce changes, because if you're working towards that, you know that you're getting it right. And interestingly for us, regarding the buddy system, we actually already were hitting 95% with our risk assessments, and still do. So that's not actually a problem. That's very, very well embedded in our practice. But the view is, if you're doing that, then that's okay. That's VTE done, that's ticked. But it's not. And so what I'm trying to do is put the processes in place, put the pathways, look at the VTE champions, build up some expertise within the hospital, and some enthusiasm and education as well. And so having the buddy system, I'm very lucky to be buddied up with Guy's and St Thomas's. They're absolutely brilliant. And it gives me the expertise that we don't have. So like Bex was saying, we don't have specialist hematologists who have an interest in thrombosis and hemostasis. And we don't have a hematologist chairing the thrombosis group. We currently have an interim gastroenterologist. So there's a big gap there. And who do I go to for that expertise? Well, I can tap into Guy's and St Thomas's, and you know, we have pathways that aren't in place yet. They're just an email away, and it's been so positive, because everyone is we're all of the same mindset. So it's all about patient safety, and being able to be on the receiving end of people who want to share their work and what they've done. We don't have to reinvent the wheel. We know that we're going to try and have best practice and evidence-based practice. And for me, it's overwhelmingly positive.
Thanks, Claire. Yeah. And logistically, how did it work for you? Did you work with different members of the multidisciplinary team at GSTT, or did you have one link that you worked with?
So initially, so I'm really, really lucky here. So originally it was Professor Beverly Hunt. So she and I actually had a Teams call, and she was listening to me to say, and me identifying what our needs were, and she was very supportive. She got in touch with our medical director so that we could have the support from the high level here. And then I'm invited to attend their thrombosis group meetings each month. So that gives me a huge insight into how a well-run thrombosis group committee should be run, what the content should be, what they need to cover. But also at the same time, of course, I'm getting the most up-to-date information. I'm getting updates to international and national guidelines. So it's helping my learning. So I attend those meetings, and also I can email any one of those teams, and they will point me to the right person to help with whatever query I have. I ask about cancer-associated thrombosis pathway, straight away it's shared. I can talk to people. I wanted to set up a perioperative bridging clinic. I'll be able to touch in with them. These things, they're just so valuable.
Yeah. Absolutely. I think that you've really touched on one of the most important functions actually of the buddy system. It seems to me like that it's kind of twofold. One of them is the sharing of resources, which is clearly a really big thing, and actually creating these resources can be so time consuming, and it's a waste, isn't it? Also, sharing them just promotes continuity, doesn't it, across the country? If we're all working from a similar song sheet, then that promotes continuity for patients. But then I suppose the other aspect with the buddy system that you don't get, say, from, I don't know, using resources from the website, is that individuality, isn't there, that you can work with a centre and you can look at your own processes in detail and get individualised feedback on how you're working, and get some ideas to hopefully generate some improvement your end. Can you pick out one aspect of VTE prevention care that you think that you being part of the buddy system has really helped with, Claire?
Gosh, there's so many, Emma. I don't know what one. I think it's for me, it's being able to tap into a site that's already has everything in place, and that it gives me confidence. It enables me to be on the right track with everything. And when you don't have the clinical expertise and support that you would ideally want, it gives me confidence. And I think it's about what we give our patients, that patients who come to this hospital, they should be entitled to the best care, and the buddy system will help me deliver that.
Yeah, that's fantastic. And I should say as well that becoming a buddying up with an Exemplar centre, there is no expectation that you then go on to apply to become an Exemplar centre. But again, I think you picked up a good point there, Claire, that the Exemplar centre criteria is actually quite a nice framework when you are looking at improving VTE prevention in your own trust, whether or not you have any interest in becoming an Exemplar centre or not. And I think that particularly now that the NICE VTE quality standards have changed and now cover VTE prevention and VTE management, we don't necessarily have that framework anywhere else. So I think that was a good point, that can be used quite nicely, can't it? You can work your way through it. It gives you that structure.
Absolutely, and you can use it. Where are your gaps? Where have you got gaps? And what does the Exemplar framework sort of suggest that you should have? And that's what I've been able to use, and it hasn't made it so overwhelming. There are areas that you could do quite well at, and then there are areas that are really poor, and what do we want to do to plug those gaps? So yeah. It's really helpful.
Yeah, you can break it all down. And I'd like to ask you and everybody actually on the panel today, before you engaged in the buddy system process, did you have to get permission from senior colleagues in the trust from the exec level, or was the encouragement there and you could just go ahead with that?
We had senior level approval.
Yeah,
I think that's quite important to have that, really.
Yeah. And how about you, Natalie?
We were really left to our own devices to get on with it. And I think the getting it right first time report was very helpful in kind of pushing my agenda, to promote this within the trust, and that I found really, really helpful to, get more senior management interested and involved, because I think perhaps they're slightly more guided by numbers and data and what targets need to be hit. So that was helpful, but no, we didn't need to get any senior approval.
Yeah, they were just grateful that it was taken off their hands.
Pretty much, yeah.
Yeah, and I think you're right. The GIRF report also acts as such a good driver, doesn't it, and a very good framework as well for moving forward with improvement. And if I could ask any of the panel, actually, if there is anything that you think would help the buddy system be even more effective going forward.
Perhaps a forum, a place where it's easy to share pathways and policies and SOPs, that type of thing would be helpful, because I think sometimes policies and pathways from a large tertiary centre may not be applicable to a very smaller or medium-sized district general hospital, and actually just having access to those documents and pathways I think would be useful.
Yeah, no, that's a very good point. I'm sure that's something we can do actually with the website. Yeah, and you make a good point as well that that sometimes it's although it might give you a starting point, a policy from a hospital that's very, very different in its nature to your own may not be that helpful. Thank you. Were you going to come in there, Bex?
Yeah, only sort of a similar thought really. Actually, do we link? So we've got established the NNMN, which is enormously helpful. I'm not a nurse and I'm a member, and it's just massively helpful because we're all trying to do the same thing. I wondered if there's an equivalent for non-members, non-exemplar centres who are trying to improve, not even, as you say, necessarily to become exemplar centres, but who are really trying to sort of get this sorted out, whether that networking between or even overlapping would be helpful. Because as I said, we're all learning from each other, and I actually think what Sue's point about this is a slow win, this is a long slog. So just that sort of, little nugget of how it's gone well or small win, just encourage and might be helpful.
Yeah, absolutely. And I think just having like-minded people around you, like several of you have mentioned, to be able to just debrief with a little bit and just to take stock is quite useful, isn't it? And just to say as well that the Nursing and Midwifery Network is not exclusive, certainly not exclusive to the VTE Exemplar Centre network. We invite anybody really with a passing interest in VTE and anti-coag to join. And again, you can, if you would like to join, then you can find details on the vteengland.org.uk website. And we all help each other, and we've got one of the main functions actually of the network is sharing and supporting each other. So I get several queries a week from colleagues around the country asking if I would ask the network on their behalf a clinical query, or sometimes asking for a resource like a policy. And we've had somebody today from one of our exemplar centres asking for a paediatric VTE management and diagnosis policy. They were unable to find one. I've not checked my emails to see yet if we've got any back, but usually by the end of the day we've got a trickle of emails back. which is hugely helpful. It just saves an awful lot of time, doesn't it? And you know that support's out there. So if you're listening and you are interested in joining, either drop me a line or have a look on the website, and there's a very short application form to fill in to join the National Nursing and Midwifery Network. Similar but a different thing to the buddy system, but I think they go hand in hand quite nicely. Becky, is there anything that you would add, Becky Simpson, anything about the network setup or the processes for the buddy system you think that could improve it in any way, or any way that we can develop it?
I mean, I think there's always room for improvement and development, isn't there? I think, you know, I've had an exceptionally positive experience from it, so I'm finding it quite hard to think of any ideas. I'm sure there are some, but I think it's just having that accessibility to somebody, isn't it, to bounce an idea off if you have a query, if you're concerned about something. I just think you can't beat that, really.
Yeah, and actually it's built into the criteria now. I think all VTE Exemplar centres that we currently have, which is 38, I'm pretty sure that they would all be willing to take on a buddy system, a buddy centre. But actually moving forwards for all new Exemplar centres, it is written into the criteria that they have to take that on potentially. And we've got one centre at the moment actually that's buddying 2 centres, which I think, you know, the time commitment isn't huge, is it? And so maybe going forward, it is possible to buddy up with more than one centre at one time. And then I guess the future is that those centres, whether they go on to be Exemplar centres or not, those centres can then buddy other centres. And we've tried to buddy and match centres up that are fairly similar in terms of their size. Geographically, I think it's kind of nice if it's fairly local, so that you've got a bit of an appreciation for perhaps the demographic that hospital serves. But I don't think that's the most important thing. But would any of you disagree or have anything to say about the way that you're paired up with another centre?
I think you're right. I think kind of the size of the hospital is probably one of the most appropriate criteria. So pairing up with a, you know, medium-sized district general hospital is for us, you know, has been great. I mean, we've done all our meetings through Teams. So, you know, I think nowadays that's a great way forward. So I don't think you have to necessarily be in the same kind of nearby area.
Yeah, thank you. Anybody else want to add anything to that? Obviously, Claire,
I would say that.
Sorry, go on, Bex.
No. I would say that it's helpful, actually. So although we haven't met physically with our buddy centre, I think having an appreciation of some of the pathways within the region is helpful. So they're a tertiary referral teaching centre in the same way that we are, but just having an idea of some of the things that are happening regionally. So we're in the Yorkshire and Humber region. I know it's a big region, but I don't know, maybe because I've been there as well, maybe that helped me, that I could visualize the buildings and you know, different aspects. Maybe it's just that. And I know that's this is a pre-COVID approach, isn't it, that we have to physically see and be, but I have found that a helpful element for us. Probably not as important as a similar match in terms of patient numbers, specialties, DGH versus teaching and all that. But actually, I think there is a bit of an understanding that we share in terms of regional ways of working.
Yeah. Absolutely. And I think as far as I'm aware so far, all of the buddy sites have had virtual meetings. But interesting moving forwards though, if anyone does decide to have a site meeting, because I think you probably could gain a different perspective. When I've been lucky enough to go to some prospective Exemplar centres and you know, go and visit the department and get to know the MDT and listen to a presentation, you do learn an awful lot. And I'm always there with my notebook jotting down ideas. And like you say, the opportunities for the learning to be both ways are fantastic. We've got a question asking about whether there's anything similar for primary care around a DVT service, which, as is often the case, is integrated into an urgent care centre. Now, there isn't anything formal that I'm aware of, but I think that you're definitely not alone. There are a lot of DVT services integrated into urgent care centres now. So I would perhaps say to reach out to somewhere local and ask around a little bit and see if there is somewhere that perhaps you could request to buddy up with, because like I say, I think that's quite common now, but there isn't a formal buddy system in place for that I'm aware of. The other question we had that was a follow-on from the question earlier about the issues with reporting VTE risk assessment, which we are all very familiar with those difficulties, says that it's the IT system that's to blame and is there a recommended system? And I think we would probably all answer the same. There isn't a recommended system. There certainly isn't a system that's perfect. I think all of them have needs work, and there isn't a system that's set up for VTE prevention data collection. Nationally, there are conversations now about how we move forwards, because since COVID, the census data hasn't been collected and published nationally. And our last National Nursing and Midwifery Network meeting, Professor Rupanaria talked to us and tried to get opinions and a bit of a sense check about how we would like to see that going forwards, and whether we would like the monthly reporting to continue, how useful it is. The colleague that has written the questions says that actually it probably is happening. The risk assessment probably is happening. More importantly, I suspect the VTE thromboprophylaxis is also probably being prescribed, which we do see a lot, don't we? So I think it's a good time to sort of have a little bit of a refresh and think about how we spend our time and make sure that we use that wisely, and have another look at whether collecting census data is a good use of our time. I think it's there are two sides of every coin, aren't there? And I think that the benefits are that it maintains awareness, and it also helps you to be quite proactive and spot trends very, very quickly. And you know, sometimes you just know that there's a new doctor in a certain area because you can see it on your data straight away, and you're able then to intervene and nip that in the bud. If we moved to, say, quarterly VTE risk assessment data collection, then that may be a little bit more difficult. It may feel a little bit more retrospective, and we lose that opportunity then. However, like I say, we're all very patient safety orientated, and we've probably got a fairly good feel now for how effective VTE risk assessment is at actually protecting our patients from harm from VTE. And perhaps, like I say, it's might be better that in future we spend more time looking at appropriate thromboprophylaxis and learning from hospital associated thromboses. So that's something that's in progress at the moment, and watch this space, because it may well be that we have some answers coming out from that question over the next few months. We're heading towards the end of the session, but I just wondered if anybody on the panel had anything else that they wanted to add, or if there are any other questions from the audience that you might like to pop into the chat or the Q&A now.
I was just going to say about the, obviously we're buddied with Gbson St Thomas's, that's a teaching hospital, we're just a DGH. For me, it works quite well because it's the clinical aspect that I get from them, and also geographically, we're quite close. A lot of our patients have shared care in London hospitals, so that's a factor. Although I completely take on board that ideally you'd want to be matched with somebody maybe the same sort of size hospital, but for me, I feel very lucky that I'm buddied up with Gbson St Thomas's.
Yeah, no, I think that's true, isn't it? It can work with different size centres equally as well. I guess it depends on what you're wanting to achieve, doesn't it?
Yeah, I need to be aware that you're going to have to adapt whatever you're seeing for your site. It has to be appropriate and work for your your patients, you know.
Yeah, absolutely.
A lot of the specialist stuff that happens there won't be applicable.
Yeah.
But that's still quite good for knowledge as well.
Yeah.
For our knowledge.
Yeah, absolutely. Well, I think that draws the session to a close, and I hope that our listeners have found that useful today. I've really enjoyed hearing a little bit about how you're finding the buddy system. It's fairly new, and like I say, it's good to know that we're going along the right lines, and what the future of the buddy system might well be. It does sound like it's a valuable option. And so I look forward to hopefully revisiting this again next year, and we'll have a lot more buddy partnerships by then. So I'd like to thank the panel very much for giving up their time to join us today, and for all their expertise and sharing their experiences. It's been absolutely invaluable.